Dr. Sheera KR from Aradhana Institute, Trivandrum. She is a BR surgeon. Over to you, Dr. Sheera.
Comes to our mind, and I will be rushing through all these features and the salient points. First of all, the retinoblastoma, we can see the incidence of retinoblastoma in India is very high, and it's the most common intraocular malignancy in childhood. And the most common presentation is leukocoria and squint, and the other rare presentations are red eye and inflammation. And germline mutations can be seen in all bilateral retinoblastoma and 10 to 15% of unilateral retinoblastoma. And you can see the most common age group in a unilateral case it's 24 months, and in a bilateral case it's around 10 months. Retinoblastoma lesions can present as an exophytic growth or an endophytic lesion. In an exophytic lesion, the mass lesion grows towards the subretinal space, and we can see the retinal blood vessels very clearly. And in an endophytic growth, it grows towards the vitreous cavity with vitreous seeds, and the retinal blood vessels may not be clearly visualized. Coming to the evaluation of retinoblastoma, the most important thing is detailed examination under anesthesia and the B-scan from the ophthalmic side. And the metastatic workup include detailed physical examination, regional lymph node examination, chest X-ray, ultrasound abdomen, bone marrow biopsy, CSF cytology, and MRI brain and orbit, which has to be done in all cases, and to rule out a trilateral RB also, and technician 99 bone scan. These are the international classification grouping we follow, group A, B, C, D and E, and E is the extensively spread form. And when coming to the treatment of retinoblastoma, the major treatment options are chemotherapy and local treatment. Chemotherapy can be by intravenous chemo, intraarterial, periocular and the intravitreal. And the local treatment mainly by transpupillary thermotherapy and cryotherapy. And other options are radiation in the form of EBRT and enucleation. These two options are nowadays not done because of this intraarterial chemotherapy. We can salvage the eye even if it's advanced grade in many of the time. This an intraarterial chemotherapy. The catheter is introduced through the femoral artery, and the edge of the catheter is opened up into the ophthalmic artery, and the chemotherapeutic agent is injected so that the maximum chemotherapeutic agent concentration is focused in that eye affected. And so in an advanced case also we can attempt for the salvaging. Now coming to the choroidal nevus, which is actually an incidental finding, usually presents as flat or minimally elevated pigmented lesion. It can be amelanotic also. Overlying drusen or RPE changes implies the chronicity of the lesion, and the risk for malignant transformation is very rare in case of nevus. How can we identify the malignant transformation? The things which we have to look in each follow-up is thickness of the lesion more than 2 mm, and presence of subretinal fluid, presence of symptoms, orange pigment overlying the lesion, and the margins touching the optic nerve head or within 3 mm, and ultrasound hollowness, absent halo, and absent drusen. If any of these signs are not present, then we can safely follow up the patient annually. And if one or two features are positive, we have to see the patient every 4 to 6 month time. And if three or more signs are positive, then the patient has to be evaluated in an experience center for the further management. Yeah, usually choroidal nevus doesn't warrant any treatment, but occasionally the nevus can present with the symptoms even without malignant transformation with the presence of choroidal neovascularization. In such a cases, patients need intravitreal anti-VEGF injection. Now coming to choroidal melanoma, it's the most common primary intraocular malignancy in adult, and 85% presents from the choroid, and primarily it's sporadic, but it can be associated with the dysplastic nevus syndrome. And the most important thing is tumor size directly correlate with the chance of metastatic spread, so early detection is very important in a case of melanoma. In the B-scan, the characteristic findings are acoustic hollowness, choroidal excavation and orbital shadowing. And in FEICG, we can see the double circulation. Retinal detachment and lipofuscin orange pigment deposition is seen in a melanoma lesion, and less frequently it can cause severe glaucoma, cataract and even extraocular extension to the orbit. Such a situation it will be in a poor prognosis. And the common metastasis will be into the liver through the hematogenous spread. The treatment options are radiotherapy by proton beam or plaque brachytherapy with a high local tumor control and a 90% of the salvage rate. Now coming to the ocular metastasis, choroid is the most common site because of the highly vascular nature, and in case of males, lung is the most common primary site, and in case of females, breast is the most common site. Usually it presents as yellow creamy subretinal deposit, but it can have an orange color, especially in case of renal cell carcinoma, carcinoid tumor or thyroid cancers, and in brown grey color in case of metastatic melanoma. And the most common characteristic finding in an ocular mets is disproportionate subretinal fluid compared to other primary lesions. In a B-scan, we can see high reflectivity on B-scan, and in an echo dense on the B-scan picture. And in OCT, lumpy bumpy choroid with thickening of the RPE and overlying subretinal fluid. In angiogram, we can see hypofluorescence in the early phase and heterogeneously hyperfluorescent in the late phase with pinpoint leaks. So choroidal metastasis, the treatment basically is the controlling the primary tumor, and the local treatment options are intravitreal injections of anti-VEGF or intravitreal chemo agent injection, photodynamic therapy, or in external beam radiotherapy. Now coming to choroidal osteoma, it usually presents as a benign intraocular lesion which is composed of mature bone cells and classically manifests as an orange-yellow plaque lesion most commonly located in the peripapillary region, and typically seen as a unilateral condition in a healthy young female in the second or third decade of the life. Usually it presents as asymptomatic, but depending on the location it can rarely present as visual blurring, metamorphopsia or visual field defects. The complications of this choroidal osteoma are enlargement of the basal diameter and leakage of subretinal fluid and development of subretinal neovascularization with or without hemorrhage. The management options are observation if there is no other complications, or use of intravitreal anti-VEGF agents can be used in the case of subretinal fluid or neovascularization. Now coming to choroidal hemangioma, benign vascular hematomas are there, and they are classified into circumscribed form or diffuse form. Circumscribed form usually occurs sporadically, and diffuse form usually is associated with the Sturge-Weber syndrome. This circumscribed form usually presents in around 4th decade of the life and mostly asymptomatic, and appears as orange colored mass with indistinct borders. And in ultrasonography we can see a dome-shaped choroidal lesion with high internal echogenicity, and in FA-ICG we can see late leakage in FFA and a complete filling of the tumor with superimposed hypo or hyper spots in ICG. Management of this hemangiomas are in asymptomatic cases monitoring or use of oral beta blockers or laser photocoagulation and Visudine PDT can be used. And in case of resistant tumors or in case of large lesions, EBRT or brachytherapy is the treatment option. Now coming to the retinal capillary hemangioma, it's a benign retinal vascular tumor sporadically seen or in association with VHL. The mean age group is 25 years. And the main characteristic finding is prominent feeding vessel and a draining vessel, most commonly located in the temporal quadrant. The most common symptom is visual deterioration. Here also the treatment include, in case of smaller lesion, observation, or in a larger lesions, laser photocoagulation can be done to the tumor and also to the feeding vessels. Other options are cryotherapy and PDT and plaque brachytherapy. In advanced cases with retinal detachment, VR surgery is the option. Now coming to vasoproliferative tumors, these are also benign tumors, can be seen as an isolated lesion or it can be seen secondary to the retinal injury, ischemia or inflammation. Basically observation is the initial treatment, and if it's vision threatening then laser photocoagulation, cryotherapy, plaque brachytherapy, intravitreal triamcinolone injection or intravitreal anti-VEGF injection or vitreoretinal surgery depending on the location and size of the tumor. Now coming to intraocular lymphoma, it can be primary or secondary. Primary means it's associated with the primary central nervous system lymphoma, and secondary means lesions originating from outside the CNS by metastasis to the eye. It's predominantly B cell in origin. OCT shows characteristic findings with the vitreous cells, intraretinal and subretinal infiltration, outer retinal fuzzy borders, PED and SRF. And in FA-ICG we can see initial blocked fluorescence due to the lesion with edge leak and late staining. Intraocular lymphoma, the diagnostic modality is biopsy of the vitreous and retina and flow cytometry, immunocytochemistry, interleukin detection and the ratio of interleukin 10:6 ratio and a PCR amplification. And treatment basically involves methotrexate based systemic chemotherapy and also intravitreal methotrexate injection and the EBRT. But for intraocular lymphoma, the prognosis remains poor depending on the lesion size. Thank you.